Welcome to Risk Adjustment Documentation and Coding for Providers. Today's topic, psychiatric, alcohol, and drug disorders. Psychiatric, alcohol, and drug disorders are common conditions in the risk adjustment model. However, there are specific documentation and coding guidelines that we will review today. In addition, it is important to note that psychiatric conditions can be present for years. Document and code these conditions even if they are stable or well controlled. Another point is that alcohol and drug disorders are applicable in the risk adjustment model even when the patient is in remission. It is important to document and code all of these conditions at least once in a calendar year, even if the conditions are stable. However, if a condition has resolved, then the diagnosis should not be included on the claim. As always, documentation must show MEET, that you have monitored, evaluated, assessed, or treated the condition, and to be included in the risk score, the diagnosis must appear on a claim. Today, we will discuss the common psychiatric and substance disorders that are applicable to the CMS HCC risk adjustment model. Let's begin with alcohol disorders. The diagnosis of alcohol dependence will contribute a coefficient to the risk score, but the diagnosis of alcohol abuse or alcohol use will not unless there are any related physical or psychiatric complications. So if applicable to your patient, I would recommend using documentation of alcohol dependence or that the patient is an alcoholic or has alcoholism. Documentation of alcohol abuse or alcohol use will not affect the risk score unless you specify a secondary complication. Documentation of alcohol dependence in remission will also contribute to the risk score. So looking at the table below, the first diagnosis, alcohol abuse uncomplicated, has no HCC value. But if you said alcohol dependence unspecified, or that the patient was an alcoholic or had alcoholism, that code is F1 0.20 and it has a coefficient of 0.420. Even if the patient has alcohol dependence with remission, that also has the same coefficient. If you again use the term alcohol abuse or alcohol use and you link it to a physical or psychiatric complication, then you will get a similar coefficient. So alcohol abuse with intoxication unspecified or alcohol abuse with an alcohol-induced mood disorder will give you a significant coefficient for the risk score. Drug disorders have a similar documentation guideline. The diagnosis of drug dependence will contribute to the risk adjustment methodology, but the diagnosis of drug abuse or drug use will not unless there are any related physical or psychiatric symptoms. So if applicable for your patient, I would recommend using documentation of drug dependence. Documentation of drug abuse or drug use will not affect that risk score unless you specify a secondary complication. Documentation of drug dependence in remission will contribute to the risk score as shown below. So in the table below, I have included only two drug classes, and that is the opioids and cannabis, but there are many other drug classes specified in ICD-10. The first line shows opioid abuse uncomplicated, and you can see that there is no HCC value with that diagnosis code. However, if you documented opioid dependence, then there is a coefficient of 0.42. Opioid dependence in remission has the same coefficient, and if you wanted to use the phrase opioid abuse and you linked it with a secondary psychiatric or physical disorder, such as opioid abuse with opioid-induced mood disorder, then you will get a significant coefficient. Not to complicate matters further, but there are two tiers to alcohol and drug use disorders. ICD-10 has specific codes for alcohol and drug disorders that have associated psychiatric symptoms. These symptoms can be persistent dementia, delusions, psychotic disorders, hallucinations, or persistent amnesia. If you have a substance use disorder that has any of those symptoms, they will trump any substance abuse disorder that is unspecified or a simple dependence. Currently, though, these categories have the same coefficient weight, so there isn't a significant change to the risk score if you pick one category or the other. However, the models will be changing in the next several months, and it is possible that the more complicated alcohol and drug disorders will have a higher coefficient. So in the table below, you will see that alcohol dependence unspecified is in category 55 with a coefficient of 0.420. However, if you have alcohol dependence with alcohol-induced psychotic disorder with delusions, then that category 54 will trump category 55. At this time, the coefficients are the same, so it will not matter. But again, this may change in the future. Let's finish with some common psychiatric disorders, which once again illustrate the need for specific documentation and coding. Providers will frequently document that their patient is depressed or the patient has depression. This will code to F3 2.0, major depression, single episode, unspecified. This code is only an RxHCC and will not contribute to the risk score. For major depression, you must document major depression and specify if the patient has single versus recurrent, the remission status, and the severity. Other conditions such as generalized anxiety, dementia, OCD, phobia, trichotillomania, ADHD, PTSD, and mental retardation are only RxHCCs. The highest weighted category for psychiatric conditions is for schizophrenia, and I have shown 3 examples in the table. Paranoid schizophrenia, schizophrenia not otherwise specified, and schizoaffective disorder would all have the same coefficient of 0.49. If, however, you use a less specific diagnosis of delusional disorders, then you will see that the coefficient decreases to 0.33. Another important category of diagnoses is for bipolar disorder. I have only included 1 in the table below, but there are many to choose from, so please pick the most appropriate code for your patient. So in summary, psychiatric, alcohol, and drug disorders are common conditions that have specific documentation and coding requirements. Psychiatric and substance disorders are applicable to the risk adjustment model even when the patient is stable or in remission, so it is important to document and code all clinically relevant active and chronic conditions that impact the care of your patient. Documentation must show evidence of MEAT, that you've monitored, evaluated, assessed, or treated, and do not code conditions that were previously treated and no longer exist. Documentation in the assessment and plan is preferred, and please ensure that all relevant diagnoses are documented and put on a claim at least once in a calendar year. Thank you very much for listening.